Hello and welcome to the first session of our online A to Z in dental implant therapy. There'll be 6 sessions. In each of those sessions, we'll try to cover the things most pertinent to implant dentistry as we see it today in 2007. Probably the biggest change in implant dentistry over the last few years has been the realization that we need to respect the biology to the point of giving us predictability of how the final restoration will turn out based on where the implant will be placed. So for us, it's very exciting to have that predictability, and we'd like to share that with you. This session will be involved in first understanding that biologic predictability, and then what are the restorative issues. So this is probably the most important core of all the sessions to follow. So I think when we look at implants and practice success, probably the most exciting thing in my office has been the realization of really how straightforward and reasonable implant restorations can be. And there are certain keys, though, to create the success that we all want to have. I think the bottom line is that we create or develop an environment where all tissues, including soft tissues, are stable. I don't believe that we can include a success an implant situation where the soft tissues are continually changing, or you'll read about creeping attachments. We find that unreasonable, and we should have stability, and in fact, on the great majority of our cases, that's what we see. In order to have that predictability, we need bone, and the bone needs to be present to allow the development of the soft tissue with that stability that we find so important. The correctly sized implant needs to be in a specific biologically compatible position to produce the aesthetically and functionally stable results that we desire to have the success that we're looking for. But ultimately, especially from the restorative point of view, success depends on the patient's acceptance of the final result. This is achieved through patient education and communication skills. So part of these sessions certainly is evaluating and examining how we can talk to patients, how we develop a relationship with them that keeps them on our sides and makes them understand the advantages of implant dentistry as well as the challenges and the limitations of any dental restoration. Another way to look at the biologic basis of our philosophy is that restorative success is dependent on the implant being in the right position. This position is determined by basic biologic parameters. If healthy bone exists or is created in the right position, and the implant is placed according to these biologic principles, the correct aesthetic display of the soft tissue will follow. For me as a restorative dentist, I need in my general practice the confidence that I can restore it to the level that the patient requires for their appreciation and acceptance of that result. We need to be able to predict to the patient what the final result will look like. It isn't just stick the implant into the bone and hope that we can achieve whatever result it might be. We should be able to look at the case, have a consultation with our surgeon to understand what the surgical complexities might be so that we can speak intelligently to the patient about a range of possibilities that they may encounter in the final result. Our skill as restorative dentists come into play in that we can take sometimes less than ideal implant placement and still make it look acceptable to the patient. So that's our skills, but we really prefer, and if we can begin with a case with the implant placed ideally, then we get a much better and more predictable result. To achieve all these things, certainly I'm a strong believer in having talented people working with me. I, as a restorative dentist, understand the challenges that I face, and I understand that if I have a very good surgeon and a very good laboratory technician, I can achieve at the highest possible level. Part of my job certainly is communicating with the patient what these results might be and the limitations of them. My great appreciation is when the surgeon also sits down with the patient and talks about the restorative challenges and not just glosses them over. Don't worry, the restorative dentist will take care of that. I need a team effect really with the surgeon so that we can both examine the challenges that are ahead of us and then create a good working environment with the patient as well as everyone else. From the office staff point of view, they need to reinforce and support the things that we say to the patient. Quite often I might say a lot of things to the patient and I feel that they understand it well, but then as I leave the room I notice that they're asking the office staff the questions that I thought were handled very clearly while I was there. So it's very important for everybody to be on the same page. And certainly for all of us, for the restorative dentist to understand the limitations surgically, and for the surgeon to understand the limitations restoratively. I sat down and I thought about what the potential issues might be in terms of restoration. I've said already that I love ideal implant placement. I haven't really defined that yet, but we will. With ideal implant placement, it's almost anything that I do will give me the correct emergence profile, the correct interdental papilla, and then with a reasonable laboratory effort, we can have a nice aesthetic restoration. But what do we do when we have non-ideal implant placement? Whether intentional or lack of actual planning, but we end up with a situation that isn't ideal. And then also compounded with the fact that we've lost our soft tissue contours. How do we handle that? It isn't guaranteed that we won't get an ideal result. It's possible that through careful manipulation of the soft tissue, we might be able to create still a wonderful emergence profile, a nice aesthetic frame to the restoration with the soft tissue, but there are limitations, and sometimes the limitation might be a lack of soft tissue and or bone, and the restoration that we must develop will be require some prosthodontic management of that soft tissue defect. It also might require a different contour to the interdental porcelain. It might require the use of pink porcelain, restoration of adjacent teeth, and even the use of removable overlays to achieve the aesthetic result that the patient wants to have. Another thing we need to look at, which remains still a somewhat controversial topic, is immediate placement and provisionalization. The reason it may be controversial is that there's a range of techniques that are seen, and some techniques are not as conducive to immediate restoration as others. But when we can successfully place an implant immediately with the extraction of the tooth, without the loss of the soft tissue contours, if we can maintain that, to me that can be one of the most conservative ways of managing a case possible. But of course it's not acceptable to look at a lower success rate just because we're placing immediately. In fact, we should strive for a higher success rate because of the situations that we're in. All right, now when we think of ideal implant placement, we realize that placing the implant in the right position allows the restorative dentistry to occur more easily. But for the restorative dentist, it's also how we manage the case. This is a young man that had an encounter with a baseball, instead of in his glove, in his mouth, which fractured off tooth number 7, leaving only a fragment above the tissue, broke the corner of tooth number 8, avulsed 26, and broke the corner of 25.